So periprosthetic fractures around total knee replacement is a nightmare, and broadly it can be classified into intraoperative and post-operative. What I will be dealing in this presentation is post-operative periprosthetic fractures. So there are general risk factors. The patients with poor bone quality, advanced age, patients on steroid, rheumatoid arthritis are likely to develop or sustain periprosthetic fractures. If you are notched your femur while doing TKA, stiffness in the total knee post-procedure, patients, epileptic patients or patients with myasthenia, polio. So these are the subset of patients who are likely to develop periprosthetic fractures, and we should be watchful in these patients. The incidence is around 0.3 to 2.5% if you go through the literature, and for the femur, distal femur periprosthetic fracture, high risk is there whenever you are notched the femur. So you should be really careful if you have done that, and you should be careful in post-op rehab protocol in such patients. Rotationally constrained implants, again high chance of distal femur periprosthetic fractures. Lewis and Roraback classification is used. Type 1 is undisplaced, type 2 is displaced, and type 3, whether it is displaced or undisplaced, but it is with loose prosthesis. So this is broadly how distal femur periprosthetic fracture is classified. Su and Associates classification based on type 1 is proximal, it is metadiaphyseal region. Type 2 fracture originates proximal and goes proximal, so it is not underneath the femoral component. And type 3 is fracture line is distal to the upper edge of the anterior flange of the femoral components. So based on this classification, there are general guidelines how we can manage these periprosthetic fractures. So casting and bracing is typically indicated in for non-displaced fractures, stable fractures with stable prosthesis. Operative is with antegrade nailing is Su type 1, where it is metadiaphyseal or diaphyseal fractures we can treat with antegrade intermedial nail. Retrograde nailing is indicated in Su type 1 or type 2 fractures with open box femoral component. If it is a closed box, we cannot go for retrograde intramedullary nailing. Fixed angle device is indicated in patients with stable prosthesis, type 1 or type 2 Su or Roraback, Lewis Roraback types. Fracture distal to the flange of the anterior femoral component, and it can be combined with retrograde intramedullary nailing for offering or adding additional stability. Revision to long stem is indicated in patients with loose femoral component or Lewis Roraback type 3 or Su type 3 patients with poor bone stock. So on table, if you find it is loose and it is a crushed bone, poor bone stock, you can go for revision prosthesis. Distal femoral replacement, again elderly patients with very poor bone stock, it is indicated, and there is no major difference in complication or reoperation rate versus ORIF when you consider distal femoral replacement in these patients. Tibial periprosthetic fracture, specific risk factors are prior tibial tubercle osteotomy, component loosening if it is there and patient keeps on walking and that component is likely to sustain that, component malposition and insertion of long stem tibial component where that stem is hitting the cortex. Felix et al. Classification states is the type 1 is it is a fracture of the tibial plateau. Type 2 is fracture adjacent to the tibial stem. Type 3 is tibial shaft and distal to the component. And type 4 is tibial tuberosity fracture. So treatment again, undisplaced fracture can be managed conservatively provided implant is stable. Operative is indicated in unstable fractures. And long stem revision prosthesis is indicated in displaced fracture with loose tibial component. Patellar periprosthetic fractures, again incidence is 0.2 to 21%, It is rather femur or tibia incidence is less, but patella fracture incidence is more in the literature. And typically you see this in with central single leg peg implant, which is commonly, and in thin patella, if patella thickness is less than 12 or 13 millimeter and you resurface the patella, very high probability that patient will sustain patella fracture post-operatively. Metal back patellar component and inset patella component, again these types of implants, patient is likely to develop patella fracture. Goldberg classification states type 1 is not involving implant or cement interface, type 2 is involving implant or cement interface and disruption of the quadriceps mechanism. Type 3 is inferior pole with patellar ligament rupture, type B is with intact patella ligament, okay. And this is how, so this is type 1. And with stable, we can conserve this, where all other types you need operative treatment. So, sharing here a couple of interesting cases. 50-year-old male known as of achondroplasia, dwarf patient, height was just 4 feet, and we did TKA using custom-made prosthesis here. And this is his pre-op X-ray, post-op X-ray, and pre-op gait. But he had a fall. This is his, and this is how he presented to us. But femoral prosthesis was stable, so it was fixed with distal femoral plate, and we could achieve a stable fixation. Another patient, 74-year-old female, bilateral knee OA. Bilateral TKA was done in 2015, and 8-year post-surgery, she had a fall injury, and that's how she presented to us. And this is how it was fixed. Why it was fixed using a plate? Because there was excess femur bow, but that's not the end of the story. 6 months, she had again a fall and developed a fracture. So this early fracture healed, and now she developed fracture proximal to that, and we had to revise that with a longer plate, and now fortunately she is doing well. Third case, 75-year-old lady, and operated 7 years ago. She had an infection, implant removal, and she was due for her second stage. And she had a, she had an infection on the right side 3 months after the index surgery, for which orthodesis was done on the right side. Now on the left side, she had an upper fracture. So the only leg, on the left side, she was walking. Right is orthodes or fused knee. And this is how she presented to us 6 weeks after the injury. Initial surgeons tried to conserve this in a long knee brace. So opposite knee is fused, and this is how we did it. So we should know what type of implant is being used in such cases. Okay, so here PFC Sigma was used, PS design, PS implant. And this is what I did. I retained the femur. I used a metaphyseal sleeve, long stem, and rotating platform tibial surface with RP insert. So we could save her femur, and this is practical solution we had. And I could get excellent hold with this metaphyseal sleeve and with some bone graft substitutes. And this is her 8 weeks post-op video, walking comfortably. So opposite knee is fused, and left knee now she's able to walk without any discomfort. The patient, 72 years old, cellulitis 3 years post-surgery, implant removal and spacer was done. She had a fall on that spacer, and this is how it presented to us. And distal femoral replacement was done in this case because of poor bone stock, and we did not have any other option. 73-year-old bilateral TKR was done.
Dr. Adkar, your time is up. Can you wind up quickly?
Yes, last case, sir.
Thank you.
All poly TBI was done, and she had road traffic accident, and this patient had a very poor bone stock, and on table the bone was completely crushed, as you can see. And so we did not have any other option but to revise the distal femur, post-op X-ray, and this is her video at the time of suture removal. Take-home message is implant stability is paramount when you while taking the decision. If implant is stable, then try to fix it. age of the patient, bone quality and comorbidities are also guiding factor. Thank you very much.